And I like to call upon the chairperson for this session, Dr. Pungudi ma'am and Dr. Chandran sir and Dr. Arun sir.
So, good afternoon, one and all. The topic given to me is intrahepatic cholestasis. So, what is cholestasis? Cholestasis is a decrease in bile formation or flow at the level of hepatocyte or cholangiocyte. It can result from hepatocellular or cholangiocarcinoma secretory defect or from bile duct obstruction due to ductal lesions. It can also be a mixed mechanism in conditions such as primary biliary cholangitis or primary sclerosing cholangitis. And what does it cause? It can cause secondary liver damage due to bile acids induced hepatocyte injury or secondary biliary cirrhosis, or failure of the substance secreted in the bile to reach the intestine can cause bile acid deficiency in the gut, leading to the fat malabsorption or fat soluble vitamin malabsorption. How does it manifest? Usually obstructive jaundice, that is cholestasis, manifests as jaundice with pale stools, dark color urine and pruritus. And when a patient comes to you with cholestasis, we have to look out for signs and symptoms and clues to differentiate between extrahepatic and intrahepatic. Usually extrahepatic will present to you with abdominal pain or palpable gallbladder, upper abdominal mass, or evidence of cholangitis or history of any past biliary surgeries. While intrahepatic cholestasis usually will have a prodromal symptoms and pruritus will be predominant. So usually when a patient comes to the thing, after differentiating between intrahepatic and extrahepatic, we should go around with the causes of the both. Intrahepatic cholestasis usually is main of drug induced. We should look into the history of any previous drug abuse or any like antibiotics, painkillers or NSAIDs. And the next is viral causes like hepatitis B, C or acute hepatitis A. After that, if both are negative, then we should look for other causes like primary biliary cirrhosis, primary sclerosing cholangitis, or PFIC or Rggh based on the manifestations. So, mainly how we differentiate between extrahepatic and intrahepatic. If the pain is predominant, we have to look for extrahepatic. Or prodromal symptoms, usually intrahepatic. And if the patient has any history of hepatotoxins or a history of any ulcerative colitis, we have to rule out intrahepatic. And what all the examination we should look for in a cholestasis, or from head to foot we should look for any signs of any cholesterol depositions, then signs of any pruritus, and then signs of fat soluble vitamin deficiencies. So after coming to that, we should look for investigations. The investigation first we to do is ultrasound. In ultrasound, if there is a dilated ducts, then it points to a extrahepatic cholestasis. And if there is no dilated ducts, it is predominantly intrahepatic. And if there is no dilated ducts, then we should go for investigations, serological investigations for viral hepatitis or autoimmune hepatitis or other things as intrahepatic cholestasis. Usually the main symptoms as per ASL guidelines is AMA antibody. If AMA antibody is present, then we should look for intrahepatic cholestasis predominantly. So usually intrahepatic cholestasis main 4 diseases are primary biliary cirrhosis, primary sclerosing cholangitis, benign recurrent intrahepatic cholestasis and progressive familial intrahepatic cholestasis. We will look into each one of the above. The primary biliary cirrhosis initially is an autoimmune disease characterized by progressive intrahepatic duct destruction, which leads to cholestasis, and the complication symptoms are related directly to the cholestasis, cirrhosis or portal hypertension as a complication. It is usually manifest in middle-aged women. The male to female ratio is 9:1 and the annual incidence is about 49 per 1 million populations. The clinical symptom findings usually presents with signs of prodromes like fatigue, pruritus. The other symptoms like hepatomegaly, hyperpigmentation, splenomegaly present in about 10 to 25% of the persons. And primary biliary cirrhosis can also present with other syndromes. Like if in cases of keratoconjunctivitis, there is a frequency of around 70 to 100% presence of primary biliary cirrhosis. And the next, in cases of renal tubular cirrhosis, there is a 50% frequency. And other diseases like gallstones, arthritis, autoimmune thyroiditis can also present along with PBC in around 20 to 40%. The diagnostic criteria of PBC is of three diagnoses, three types. If any two of the three are present, then primary biliary cirrhosis can be confirmed. The three are, it can be a chronic cholestatic liver function test elevation with typical alkaline phosphatase more than 1.5 times the upper limit, or and elevated serum AMA, or a liver biopsy that is can give a proven of primary biliary cirrhosis. If any two of the three are positive, then we diagnose the patient as having primary biliary cirrhosis. The treatment usually is due to as bile, we can give bile acids, we can give immunosuppressants, anti-inflammatory and anti-fibrotic drugs. The drug of choice usually is a drug called UDCA. It enhances the hepatic secretion, it inhibits the absorption of the toxic or the hydrophobic bile salts and stabilizes the hepatocyte membranes. It is given in a dosage of 13 to 15 milligram per kg per day in 2 divided doses. And when given along with drugs like cholestyramine which can reduce the itching, pruritus, it should be given at least 2 hours before or after the cholestyramine is given. The next is the primary sclerosing cholangitis. Primary sclerosing cholangitis is a progressive chronic cholestatic liver disease of unknown etiology. It is characterized by inflammation, fibrosis and destruction of the intrahepatic or the extrahepatic bile ducts. It can lead to cholestasis or multifocal bile districture, and there is a high risk of cholangiocarcinoma in these cases. Usually the primary sclerosing cholangitis pathophysiology involves 4 causes, that is, it can be a immune system mediated where there is a self-reacting lymphocytes or inflammation. As a second, it could be a gut microbiome altered causes like colitis or dysbiosis. The third, it can be due to toxic injury or inflammation of the bile ducts, and the fourth is due to the genetic factors. And it presents in 4 types. It could be a subclinical phase where it is only diagnosed by cholangiographic evidence and other LFT values and all, then there is no or normal and there is no symptoms. Or it can be a asymptomatic phase where there is no symptoms but LFT is altered. The next is a symptomatic phase where the LFT is altered as well as the patient has symptoms of prodromes or jaundice. And the last is a decompensated cirrhosis in which the patient has the ascites or portal hypertension. And the signs and symptoms are similar to primary biliary cirrhosis. They are mostly the prodromal symptoms, that is fatigue, abdominal pain predominates, and other signs like hepatomegaly, splenomegaly can also be present in around 30 to 60%. In the lab investigation, usually the alkaline phosphatase is elevated more than 3 to 5 times, and there is predominant increase in the IgG levels and IgM levels. And autoantibodies like ANCA or ANA, AMA all can be present. The anti-neutrophilic cytoplasmic antibody is usually present in around 80% of the patient with PSC. And the treatment management is based on the suspected cause. If you suspect a immunomodulated, then we should give immunomodulators. If you suspect a gut microbiota dysbiosis, then the microbiome can be given like preprobiotics. If you suspect a bile acid injury, bile acid modulators should be given. And if you suspect a bile duct scars, you should start the patient on antifibrotics. There are various drugs like bile acid modulators like fursinoid accelerators like obeticholic acids and other drugs or non-hydroxycholic acids. Then immunomodulators or drugs like vedolizumab, temozolizumab, or antifibrotic agents like simtuzumab can also be used. The next is a benign recurrent intrahepatic cholestasis. This is a benign condition where there is recurrent cholestasis. Usually it presents with cholestasis, pruritus are low, but the GGT level will be low or normal, but the high bile acid, serum bile acid will be high. It is usually presents in the second decades. And genetically wise, it shares the same genes as PFIC, that is progressive familial intrahepatic cholestasis. Both the BRIC1 and PFIC1 shares the same ATPA gene as the same thing similar to PFIC2 and BRIC2. They both also share the same gene. Usually it is differentiated clinical wise by the age wise only and by liver biopsies. BRIC is usually present in second decade of life The frequency of attacks can vary from years to once per 10 years or decades. And the brick can also be of two types. The type 1 brick can be associated with hearing loss or pancreatitis, and the type 2 brick can be associated with cholestasis. And also in the type 2 brick there is a high risk of hepatobiliary malignancies. The clinical gold standard biopsy is standard for diagnosis of brick is liver biopsy, whereas central lobular cholestasis with no duct loss or there is no fibrosis. The clinical criteria for diagnosis of brick has 7 components. One is there should be at least 2 attacks of jaundice separated by symptom-free period of several months to years. The second thing is laboratory value, that is raised in alkaline phosphatase more than 5 times, and the gamma glutathione transferase should be normal or only slightly elevated. And then the fourth is the pruritus because of cholestasis. The fifth is the liver biopsy standard, and then comes the normal or extrahepatic bile duct in imaging. And the last is there is absence of any other causes of cholestasis like drugs or pregnancy. Out of this, if 5 is present, it is significant for brick. The treatment is giving antihistamines and drugs like UDCA. In severe causes, the patient can also go in for nasobiliary drainage also. But since the GGT is normal, that is the liver component is normal, liver transplant is rarely useful in this. The next is the progressive familial intrahepatic cholestasis. It refers to a collection of genetic disorders usually presents in early life. It is of 3 types: PFIC1, PFIC2 and PFIC3. The PFIC2 is very severe component, and it presents in around 60% causes for growth failure, and it is rapidly progressive. The therapy for brick is UDCA, and it is shown that it should be given lifelong, and it has been shown to reverse the fibrosis also. In PFIC, surgical management like partial external biliary diversion or ileal exclusion can also be given. The last, a small talk on cholestasis of pregnancy. It is usually develops late in the pregnancy. It causes severe itching. It typically goes away after the baby is born. Usually, it is of causes is of 3 causes. One is it could be a genetic predominance. The next is could be hormonal, especially in the age of large cases of artificial insemination or other deliveries. The hormonal injections can cause increased risk of cholestasis. The next, there is environmental factors also like selenium deficiency. And when a patient comes to you with intrahepatic cholestasis of pregnancy, the risk factors for it as prognosis are, it mainly is a fetal causes like stillbirth, pre-birth, premature birth and fetal distress. These all should be monitored. While for the mother, the risk is mainly of coagulopathy, or patient can go for encephalopathy. And when to deliver the baby during the hepatic of cholestasis is, we should monitor the child. The timing of delivery can be done as per guidelines after 22 weeks also, based on the neonatal setup that is available in your hospital, and the care that can be given. And once the diagnosis of the intrahepatic cholestasis is given, usually the patient is treated started on UDCA. Usually the dose is given in 300 milligram BD, and it can be then increased to 300 milligram TDS, and the bile acid should be monitored every week. And if the bile acid is increasing, it can be given up to even 21 milligram per kg per day. Thank you.
Thank you, Dr. Joeimon. That was a fantastic talk. And the chosen topic is intrahepatic cholestasis. And even for the gastroenterologist, when we are tackling a patient with intrahepatic cholestasis, it would be a very, very difficult task to identify the proper etiology. Most of the time, we may or may not land up with the diagnosis of intrahepatic cholestasis. So in that kind of scenario, if you are getting a patient, depends upon the age group. For example, in pediatric population, neonatal population, early neonatal population, in the adolescent age group, or if the patient is progressing to adulthood, depends upon the etiological factors will change. In your personal perspective point of view, starting from the pediatric population, what is the frequent cases you have been encountering. Apart from that, in case if you are getting a patient with suspicion of Rggh, so how are you going to progress? Is there any possibility for a Rggh patient to get progress to PFIC? Because we are coming across with certain cases. Is there any experience from your side? Apart from that, in case, if at all, we are considering any management, we need to do a battery of investigations to diagnose a patient with intrahepatic cholestasis, which most of the patient cannot afford in India. But even though, so we need to subject the patient with autoimmune work, Van de Vendel, all those things we have been doing that, and liver biopsy. So what is the criteria for us to decide we need to progress with this, and we need to set up this criteria to this level? So what is your opinion accordingly?
Clinically, if you see that when a patient comes to you, usually the intrahepatic cholestasis is like a diagnosis of exclusion. First, we should from pediatric age group, we should exclude viral hepatitis, and if it is suppose it's adolescence or anything, we should avoid taking of any drugs. Or especially now with many gym products, we are getting many patients with cholestasis picture also. So after excluding all that, the next diagnosis we should go is for the liver biopsy alone. If you are not suspecting any other causes, and if the patient is not responding to any drugs, then you should go for liver biopsy. That's a clinic practically. Okay, because the genetic testing is quite costly and it's not available everywhere, even in common places. So based on that, highly suspected of intrahepatic cholestasis as such in a presentation, it's only after you treat everything and it's not responding.
But in our center, without proper genetic workup, but it will be very difficult task for us to diagnose this. No? Even in the best of centers in Tamil Nadu, it will be very difficult to progress with the genetic workup. That is one pitfall. Apart from that, even autoimmune panel, we are having basic autoimmune panels. But apart from that, there is a list of other autoimmune panels. But how frequently we are doing the autoimmune panels for all the patients? That also is still questionable issue. Among liver biopsy, in case if the patient, because of cholestasis, if the patient landed up with evidence of any acute failure-like presentation, then liver biopsy itself is a difficult task at that kind of presentation. Probably the patient might be on transient ascites, then we need to go for evidence of transjugular biopsy. And this and all is a difficult task in managing the patient with intrahepatic cholestasis. Apart from, is there any role for plasma exchange when we are going to consider because intractable pruritus itself is a consideration for liver transplant. We are seeing some cases with plasma exchange in the background of intractable pruritus with albumin dialysis and all those things. Is there any personal experience for that?
In patients with intrahepatic cholestasis, one for acute liver failure, we have tried plasma processes and it has been of much use because patients might not be affordable for liver transplantation.
Thank you.
Sir, being a pathologist, I just want to know, in case of cholestasis in pregnancy, is there any indication that you will go ahead with the liver biopsy?
We usually don't recommend, ma'am, because the evidence is increasing bile acids itself. So we usually don't recommend liver biopsy during pregnancy. And after delivery, it usually decreases. We are suspecting cholestasis of pregnancy.
Most of the time, intrahepatic cholestasis of pregnancy will improve on its own, no need to do major things. And only thing, we need to categorize the patient with bile acid levels, whether mild, moderate, and severe. If the patient is landing up with more than 100, so at that point, the severe bile acid elevation, if it is there, then we need to consider for the patient to go for fetal compromise and all those things. The risk will be the highest to the baby also. So at that time, we need to decide the patient has to terminate the pregnancy and all those things. That's one important criteria we need to consider. Apart from that, liver biopsy, not strict point.
Thank you.
Thank you, sir, for this enlightening presentation, sir.